good day, everyone. Welcome to our ongoing Mountain Pacific Quality Health MDS coding webinar series. This month, we're hosting a Q&A with MDS expert. So there's an open format to today's webinar, and we encourage you to ask your MDS questions. To ask a question, you can click on raise hand on your next to your name, and our panelist or our host will unmute you, or you're welcome to put questions into chat. But whatever your question might be, it's likely that someone else is wondering the same thing, so please don't be shy. Encourage folks to ask questions. Our series will continue next month with a deep dive into quality measures on November 20th at 11 o'clock Alaska time. So with that, I'm going to introduce our series host and MDS expert, Jennifer Labay. So fire away to Jennifer Labay.
Hello, everybody. Thanks for joining us again. So last time the half hour went pretty fast, so feel free, as Lisa said, to put in your questions. I did get some questions in email, so while we're waiting for maybe folks to start typing in, I will hit some of those because I'm sure maybe those folks, as Lisa said, if you had the question, maybe other folks had the question as well. So one of the things that I we got some questions from the evaluations from the last full presentation that we did with our introduction to QM. So I wanted to hit those. The first question, can you tell us which states will be going to PDPM for Medicaid, and if they are, when they will start that? So for the states that Mountain Pacific Quality Health reaches, Montana, Wyoming, Alaska, Hawaii, I believe that's all of them, right, ladies? Only Hawaii is lucky enough to have PDPM that started October 1st. That is going to be with all the OBRA assessments. There is a nice map, if you're a member of ANAC, there's a nice map that they have put together. Hopefully your state would have told you and given you some instruction as to that, because your software would have to be updated to make sure that it carries through the proper way when you submit and gives you the correct stuff when you're doing those OBRA assessments. And there were no changes to the REI manual this October, which is very rare. Because of COVID, all of the proposed changes got pushed back. So we are still working off of the REI manual that is effective October of 2019. So there was no new one, although there are updated forms. So the current MDS is a different version from the October 2019 start date because of the need to allow for PDPM for those states that are using it. So it is a different version, version 1.17.2, effective 10/1/20. And there were some issues that some of you may have seen when you are submitting your assessments to the KEYS ASAP system because of that version change. So any ARDs of 930 and earlier had that issue. So you may have seen, some RUG version difference or some, MDS version difference. As long as it didn't recalculate any scores for you, you're good to go. It should stop with any ARDs of 10/1 forward. We're already halfway through, so hopefully you've seen that those have stopped. If you do see any issues with 10/1 forward ARDs, make sure you're going to the QTSO instructions, and that will give you some guidance and advice as to what the reason is for those errors that you might be seeing. CMS has a lot of tools out there for us. When people ask me questions, I'm usually able to find the information. It's just hard because you don't always know where to look. So that's why I tried to, in my last presentation, give you all of the resources possible so you could get that on your own for future reference. It's like, I feel like I'm like the Dewey Decimal System of MDS for some reason. So there was another question from our folks in Montana asking about Medicaid payments. I believe that question was forwarded on to the folks in Montana about how do you get paid for Medicaid. It's actually a set fee. I was able to find that on the old internet. And sometimes the states don't have the most up-to-date information on their websites, but Montana did. So they are just a set fee. It's not based on MDS or RUGs or PDPM or any fun stuff like that. Another question that came up was asking about care plan evaluations and how do we do a good care plan evaluation? So that could be a whole webinar in and of itself. But that is also a piece that I find is missing quite a bit when it comes to doing any reviews that I have done. The care plan is there, the dates are there, the interventions are there, but nobody has written anywhere, well, is this working? And that's part of the process for the REI. So we need to make sure that we're looking at that and saying, okay, well, how am I proving to whoever may be reading this medical record that we have reviewed that care plan and that it's appropriate and that this goal is still appropriate and that this problem or need is still appropriate. So that's really what you should be doing for each care plan. Look and see, what is this need? What is this problem? Does it make sense? Is it still a problem for this person? If it's still a problem, have they met their goal? If they've met their goal, do we still need to have this plan of care? If they've met the goal, can we discontinue it? Or is this still a risk? So do we need to change this from an actual problem to a risk now? And if that goal was not met, then we would want to indicate, well, why? What happened that we didn't meet this goal? Was the problem over or underestimated? Do we not have an adequately developed problem? A lot of times, if you don't have an adequately developed problem, it's going to be very difficult to create a goal and very difficult to evaluate because it's maybe too broad or doesn't really speak to the specific needs of that resident. Was our goal too ambitious? We didn't meet the goal because we wanted them to walk 150 feet 3 times a day and they're a quadriplegic. Well, that's a little far-fetched, obviously. So we need to make sure that the goal is appropriate for the resident, for the problem. Was the goal too ambiguous? Was this goal something that we really couldn't measure, that wasn't really easy to measure? A lot of times I see issues with dementia care plans in that it's really hard to put a care plan in place for dementia because it's so far-reaching. Are the interventions working? Did we review all of the interventions? Are all the interventions still in place? Are they appropriate? And just speaking to this just in a note, in a narrative, and depending on what software you use, a lot of softwares may have either an evaluation section for each care plan, or maybe you could do it in a care plan conference note. You could write a progress note. Some softwares do have a progress note attached to the care plan. So look and see what your software can do for you. But there really should be an overview of that plan. And even it could be as simple as continue current plan, goal being met, interventions continue to be appropriate, whatever. It doesn't have to be a huge note. I do write a note for each care plan myself. That's just how I do it. And I'm looking in the chat. I see a couple of questions. Can you describe some good versus bad care plans for dementia? Well, a bad care plan for dementia would be one that's kind of too broad to really put a goal to. So this, just saying the resident has dementia and then that they'll be, it's hard to put a goal to that. I mean, like I even have a hard time thinking of what a goal would be by just having a care plan for dementia. So ages ago, when I was a fairly new nurse in the 90s, I went to a seminar. I wish I could remember this woman's name because I would love to give her credit, but she said something that stuck. So if you have a problem and there's something going on with this resident, and you're asking yourself, should I care plan this, or how should I care plan this, or what should I care plan? Ask yourself, so what? Okay, this person has dementia. So what? Well, this dementia is affecting their ability to be safe because they make poor decisions. It's affecting their ability to eat because they forget that they have to eat. It's affecting all of these different things. So instead of having a broad dementia care plan, that's really something that should be integrated into all of the different areas that are also affecting the resident. So like they have the difficulty with remembering to eat, so they're at risk for impaired nutrition because of XYZ, also because of dementia. Really, dementia is going to be, it's going to affect so many pieces. So integrated into those plans that are already there versus trying to come up with just something that's too broad, and it's difficult for you to create a goal and manage that and measure that goal and have an intervention. It's going to be 40 pages long for all the things you'd have to do for somebody for dementia if it's too broad. So hopefully that answered your questions. It's like I said, that could be a whole day presentation. So I did see in the chat that somebody just submitted an annual MDS with an ARD of 10.5 and received the invalid version code. That may be something you want to speak to your software vendor about, because there shouldn't be. If you wanted to reach out to me offline, I can help you research that. I will put my email in the chat so everybody has it. It's jennifer@triadhc.net. So that is in the chat. If anybody has questions that they want to shoot directly to me, I'm happy to help with that, because it's not supposed to with any ARDs after 10.1. So that may be a software problem. Another question that popped up, quality measures, how quality measures are affected by the MDS. That is also a deep and big and loaded question. Almost every single quality measure that's out there is affected in some way by the MDS, with the exception of value-based purchasing, that quality measure. But even the claims-based measures are affected by MDS. For the covariates, they use different MDS portions for the covariates. So either the MDS is directly triggering that quality measure, or it's indirectly triggering that covariate, or is creating an exclusion if an MDS is not completed. So for those claims-based measures, if there is not an admission or initial MDS completed, then they're going to be excluded from that calculation, because there's no MDS. One of the things that they look at is if they're comatose or not. So if there's no MDS to look for that covariate, then that's going to be excluded. So we'll dive a little deeper into that in the November session, how the quality measures are affected by the MDS, because that's pretty much the only thing that affects the quality measures is from the MDS and the coding of the MDS. The majority of them, we've got our claims-based, sure, but the majority of them are coming from the MDS. Not seeing any questions in the chat, so I'll take a look at some of the other questions that have come through since our last session. I have responded to these folks individually, but like I said, and like Lisa said, if there's, so somebody's not seeing my email address. I'm not quite sure why it didn't show up, but yeah, maybe Lisa's post can see that. Oh, I think it's because I just did it to the panelists and not the attendees. Thank you, Lisa. So I had somebody ask a question about the behavior symptoms and how they are affecting the quality measure, and what it means as far as the behavior symptoms affecting others. So there's a little difference of opinion about how to code the behaviors. So basically looking at rejection of care. If somebody refuses something and has never expressed a dislike or desire to not do whatever it is this person is refusing, then that would be a rejection of care. So the thing to understand with the rejection of care, which is one of the behaviors that will trigger the quality measure for the survey, is that it's supposed to be based on resident goals, resident indicated goals, resident stated goals. If we are not assessing what the resident's stated goal is for their own health and well-being, then we can't really assess whether they've rejected their care or not, because they've never stated that they wanted to do something a certain way or didn't. So that's a big piece of it. Once somebody does refuse care or reject care, once you determine the reason why they don't want that care, then you can care plan it, not to say that this person was rejecting care or is non-compliant, but that you're actually saying why they do or do not want to do whatever it is you're asking them to. So I always like to use an example. I have a friend who likes to have her hair done, her makeup on before anybody sees her. She does this before she goes to the gym. I went on vacation with her and her family. She snuck into the bathroom at 4 a.m. before anybody could wake up and see her, undone. So when she goes to the home, and she's got dementia, so I'm going to be her proxy, because she had too much Aquanet in the 80s. So now she's got the dementia, and I'm going to be her proxy. So, well, this is what Kim always liked to do. She always had to have her hair done, always had to have her lipstick on. So make sure that that is part of her morning routine. So we know that that's her resident stated goal for herself, or her proxy stated goal for herself. So if she then starts to refuse that or reject that for whatever reason, then she's not continuing to be in line with what her previously stated goals for herself were. So that would be a rejection. Now, let's say when I get admitted, clearly, I don't know if you're looking at the video, but my hair's in a ponytail, I have no makeup on, I couldn't care less about any of that stuff. If I rejected having my hair and makeup done, that's not going to be a rejection for me, because I've already stated I don't care about that stuff. So even though we're refusing the same exact care, it's a rejection for her, but it's not a rejection for me, based on what our individual goals for ourselves is. So that's a huge piece of assessing that, and we need to make sure that we're looking at that first and foremost, because that's going to be what helps you to determine whether it is truly a rejection or not. Once you've established in the care plan that this is what they want, if they reject it again, it's no longer a rejection on the MDS, and it will no longer trigger on your MDS. So it's huge that we really establish that the goals, the resident stated goals, is very important. As far as what triggers the actual quality measure, when it comes to the behaviors, it has to occur 4 to 6 days or daily. So the occasional rejection would not trigger that quality measure. And the impact on others doesn't have any part of that calculation for the quality measure. It's just whether the behavior itself occurred. Let's see. It's very, very important to know that resident and hear what it is they want. So another question that had come in earlier was about Medicare Advantage plans and the use of the 5-day with the Medicare Advantage plans. So if you are required to do a 5-day assessment because your Medicare Advantage plan needs you to calculate a PDPM score, that's fine. You can do that, except for you cannot combine it with your admission assessment. So I think I had mentioned this in the previous presentation. CMS only wants 5-day assessments submitted for folks that are fee-for-service, traditional Medicare. Otherwise, it's going to clog up their system. Also, if you are submitting, if you're submitting those non-fee-for-service Medicare assessments, then your SNF-QRP calculation is going to be skewed, because the QM calculation is looking at the type of assessment, not whether you've answered yes to have they had a recent Medicare stay. That's not where the calculation comes from. The calculation is looking at the type of assessment. So the more assessments you have in the system, the calculations are going to be skewed, maybe in your favor, but maybe not, depending on how you've coded that assessment. And you definitely don't want that, but those definitely are supposed to be not submitted. They are just going to be, depending on what your software says, maybe in a completed status, just kind of sitting there hanging out. There's got to be some way in your software that shows that you are not wanting this particular assessment to be submitted, depending on how you do that. Now, if you just have a, the lower end freebie, you may have to manually remove those assessments from your queue when you're attempting to submit, but that is the process. Let's see, I did see a question pop up.
Jennifer, we have a question in the Q&A,
Okay.
but it's not quite specific yet, so I'm hoping this person will add a little bit more, but they're just asking if anyone has asked questions regarding section GG.
Oh, section GG. I'm going to guess this is probably somebody from Hawaii because now GG is on everybody there. But yeah, I would need a little bit more. So hopefully she will add a little bit more to her question. And feel free to raise your hand if you want to speak instead of type. We can certainly answer that. There are some great things about section GG for training on the CMS website. So if you go to the SNF QRP training section of cms.gov and scroll down, there are, yes, from Hawaii. I knew it had to be somebody from Hawaii. So there's some great training videos available for folks, either for the MDS coordinators or for the direct care nursing staff, to do a self-directed, self-guided web-based training. If you would like the link to that, you can email me, Jennifer@triadhc.net, if you did not see that in the chat. And I'd be happy to send you the link to it. There are also lots of video instructions for the different sections of GG on CMS's YouTube channel. So if you go to YouTube and do a search for CMS HHS, I think, they have their own YouTube channel, and there's lots of training videos there, as well as on the SNF QRP training website. So the rules for GG for state, and I haven't heard anything specifically from how Hawaii is doing it, but the instructions from the REI manual, it's section GG is section GG, whether it's for payment for OBRA, the instructions are the same. What I've been hearing for the majority of the states out there, that if it's being done for OBRA purposes, the observation period is the ARD in the 2 days prior. So you want to make sure that you have your documentation in place to support whatever you're coding. But if you aren't used to doing it, if you don't have a lot of Medicare historically, then yeah, you want to get some training in there. It's pretty intensive. There's a lot of sections, and it's very different from section G. So I find it to be a little easier as far as the instructions go, but the REI manual is going to be a good place to start, and then the SNF QRP training webpage.
So Jennifer, I'm seeing a little bit more information in the question there, asking about coding, quote, if activity was not attempted, what is the difference between coding, quote, not applicable -09 and not applicable -88?
Perfect question. Yes. Okay. This is like a hot button topic for me. So not applicable versus the 88 not attempted due to medical or safety concerns. Not applicable means before this, for Medicare purposes, before this acute illness or injury, were they able to do that particular activity? So if you have somebody who was at home, had a stroke, they now have dysphagia, they now have a tube feeding, they were able to eat before they had this stroke. So now they go into the hospital, they come to you, they can't eat. So the reason why we're not going to attempt the eating is not because they couldn't do it before and they still can't do it, but it's not medically safe for them to do it. So this is something new for them. That would be an 88. If this was somebody who maybe already had a tube feed previously, and now they go into the hospital, they have their acute event or, previous whatever's going on with them, and now they still can't eat. They couldn't do it before, they still can't do it. That would be not applicable. So I apologize, I don't have the Hawaii specific information. I don't know if the Department of Health there has put out any specific trainings related to that. I would check in with your state REI coordinator and see if there's anything more specific than what is listed in the REI manual. But the not applicable means they couldn't do it before and they still can't do it, versus the 88 medically unsafe or not able to do due to medical concerns is they could do this before, and now for whatever reason they're not able to because it's unsafe for them. They're not medically able to do it. I hope that answered your question.
I see a follow-up question there, Jen.
Okay.
Asking, what about the Medicaid resident who has been here for years and years?
That is a good question. I do not, unfortunately, have an answer because, as I said, I don't know if Hawaii's given any specific instruction related to that. So I would defer and ask the state REI coordinator. I can try to do a little research on that and get back to the group if I find something. A lot of times I do have some access to folks at ANAC who may have heard something specific for the state specific items. But I don't have any specific guidance. I just have the guidance, what's in the REI manual. My interpretation of it is basically what were they able to do on their previous assessment as far as this activity, but I don't know that that's the exact criteria that Hawaii's given, so I apologize. Don't want to say anything out of turn.
I'm not seeing any other questions in chat. I see a thank you and questions about handouts. We don't have handouts today, but we will be sending out a recording after our event. I do see one question in chat from Kay and Sitka saying, we have problems with ADLs being charted wrong by the CNA staff, even with training and coaching. Of course, this affects the ADL score. Do you have any tips?
I do. Besides training your butts off, because you could have a full-time job training CNAs on how to document ADLs, you really need to interview. That's the unfortunate thing. You have to interview the staff and find out the true picture of what's going on, because whoever is signing at Section G or Section GG on the MDS, they're the ones that are saying, yes, I attest that this is the most accurate information. So that means you need to do your darndest to get that information. And historically, the best way that I have done that is interviewing the staff in layman's terms. Another way I have done that, which I have found to be successful, is I created a questionnaire for Section G that basically asked things in layman's terms. Did you touch them? Did you pull, push, lift? And then I was able to interpret that into the Section G documentation. I'm sure we could do something similar to GG. But yeah, you said SICA, so that's Alaska, so we don't need to worry about that for your, unless it's a PDPM person for Medicare. But yeah, it's all about the interview. For anybody who's interested in that questionnaire, happy to shoot it to you. Just shoot me an email and I will give you the last thing I have of that. I'm always happy to share.
Jen, if you'll send that to me as well, I'd appreciate it. I can send that to my Alaska group. I know they appreciate it, and I'm guessing the other states would appreciate it as well.
Yeah. Sometimes it makes it a little easier. It's a little bit more of a paper trail, but it's the questions are much easier. Did you lift? Did you push? Did you pull? Did you two people touch? And it kind of asks those questions, those probing questions, especially for off shift. I mean, you can ask those questions if you're on, but what about the weekends? What about, the off shifts? You're not necessarily there. So I didn't keep that as part of my permanent medical record. I just kind of used that as my interview tool. Okay, I do see a question. If you do any documentation based on your interview, I do recommend writing some sort of an MDS note to support that, absolutely. Because all parts of the MDS do have to have supporting documentation in the medical record, with the exception of the scripted interviews. Everything else has to be supported by supporting documentation. So if you have incorrect documentation in your medical record from the CNAs, and then you code the MDS correctly, but you don't have any documentation to support why you coded the MDS the way you did, even though you have something in the medical record that says something else, then usually, at least the surveyors I deal with, they say, well, that's not what the medical record says, so your MDS wasn't coded correctly. Even though I'm the licensed nurse who filled it out, you have to write the note to support why you filled it out the way that you did. And usually it's just kind of a general, based on interview with staff and medical record review, MDS coded appropriately per the REI guidance for the observation period in question, or you can even get down to specifics. I mean, I wouldn't throw CNA's names in there or anything, but you can just say that you interviewed the staff and, they were coded this way based on your interview. And once again, the half hour has dissolved in seconds.
Well, thank you very much, Jennifer. As always, I know I learn a lot every time, and I don't work with the MDS as much as everyone on the call. So thank you for joining us, everyone, today. And thank you again, Jennifer, for your expert guidance.
You're very welcome.